I'm going to move on to the next phase of our presentations. We're going to have a team plenary, and I'm going to introduce the speakers of this plenary. We're not going to have a necessarily a Q&A right after that, because we're going to have a panel discussion, and then the Q&A can follow in that session. But please put the questions in the Q&A, and our moderator will be able to look at that. Dr. Sakalingam will moderate the panel discussion subsequent to this plenary. Introducing the speakers, I first like to say Stefan Kloiber, and I appreciate him speaking here today. He's a clinician scientist in the Mood and Anxiety division. He's the medical head of the Mood and Anxiety Ambulatory Service, and I am really grateful that he's speaking at our conference today, so thank you, Stefan. The second panelist plenary speaker is Dr. Karen Wang, who is one of our co-chairs and has a significant role as QI lead in psychiatry at Sunnybrook, has a master's in education and a child and youth psychiatrist. And thank you as well for joining the plenary. And last but not least, Dr. Marlene Taube-Schiff, who's also a co-chair of this conference, has done so much work. She's a staff psychologist and team lead at the Frederick W. Thompson Anxiety Disorder Center in OCD. It's an intensive treatment service program. She is also a QI researcher, and as I mentioned, co-chair as well. So go ahead, team.
Great, thank you, Raj. I'm just going to share my screen here. So I'll be starting off the panel presentation talking a little bit about the theory and evidence for measurement-based care. And the idea of measurement-based care has actually been around for a very long time. Back in the early 1800s, this was actually one of the first times that measurement was tied to decision-making around mental health planning. And Professor Holtz published a paper around this, where in the Kingdom of Norway, back in 1825, there was a proposal that was put forward by the clergy looking to obtain as much information as possible regarding the insane in the whole kingdom, with a view to determine the number and extent of the establishments to be erected for their accommodations. And over the last 200 years, there's been a huge development in the area of designing measurements, particularly various psychometric rating scales. This has then progressed to various research studies, including one of our most famous studies, the STAR-D trial in the early 2000s. And it was in 2006 that Trivedi sort of coined this term measurement-based care. And so I'm going to talk a little bit about the definition, as if you have done any research in this area, you know that there have been synonymous terms used with MBC, such as patient reporting outcomes and feedback outcomes. And moving forward, looking even into the future, we're now shifting in psychiatry to contemplating use of algorithms as well in treatment of various psychiatric disorders. So the definition that we're going to be using this morning around measurement-based care is the systematic administration of patient symptom rating scales and the use of those results to drive clinical decision-making at the level of the individual patient. This doesn't mean that measurement-based care replaces clinical judgment, but it does enhance the precision of our assessment and allows for us to monitor and track symptoms over time. The four key components of MBC is involving a routinely administered symptom or outcome measure, ideally before the clinical encounter, allowing the results of that symptom rating scale to be fed back to the practitioner, who can then review that data. Also, the patient will be receiving that information, and then simultaneously, there will be a collaborative discussion around the treatment plan, which is informed by the data. So why exactly are we shifting towards this paradigm of care? And there's been a couple of studies that have looked at why we sort of need MBC. So one of the first issues is that there is a positive ascertainment bias. Unfortunately, many healthcare providers tend to think that they're doing a great job even when perhaps there might be data that indicates otherwise. In fact, in some of the studies and surveys that have been completed, mental health providers think that 80% or more of their clients are actually improving as a result of being in treatment with them. But when we've looked at sort of large-scale studies involving even over 6,000 patients receiving psychotherapy, the data shows that only about 1/3 improve, and actually close to 10% are deteriorating in treatment. There was also another study that was conducted in 2006 that showed that even the most effective clinicians, so they were rated as in the sort of top 10th percentile, still would have a proportion of patients that were deteriorating. And so unfortunately, without sort of ongoing measurement of patient symptoms, it's very hard for practitioners to really gauge whether or not their patients and clients are actually improving, or whether they are believing that they're improving, but in fact, they're deteriorating or plateauing. There's also a delayed recognition of non-response. So when there was a survey of mental health providers in the UK and US, it was found that only about a quarter of them could actually pick up when patients were not doing well. There's also a tendency to sort of stall in terms of our treatment plans. Seeing patients weekly, not really sort of assessing what their symptoms are like, can sort of give us this false reassurance that they're doing fine. And so we tend to delay in terms of shifting out of a treatment mode, and this can often prolong depressive symptoms. The other reason why MBC is important is that if we actually have individual patient measures, we can start to aggregate this data, and it can be helpful to feedback to the department, division, organization, or health system in order to highlight what are some of the areas that require improvement. So this is a quote from Peter Drucker, a famous business guru, who wrote that just as a human being needs a diversity of measures to assess his or her health and performance, an organization also needs a diversity of measures as well. And performance really has to be built into the enterprise and its management. It has to be measured, and it has to be continually improved. So what kind of rating scales are we talking about when we're talking about a measurement-based care? So there are thousands of different rating scales out there, and many of them have actually been empirically validated in both research and clinical contexts. I'm going to sort of refer to a few of them in the example of major depression to just sort of highlight some of the different scales that you may consider using as well. These scales are specific to a patient's diagnosis, and other considerations that you might want to think about when you're choosing a scale is whether or not your context is such that it models more of an outpatient context or an inpatient context. You might also want to think about your patient's ability to comprehend the question items, how long it would take to actually complete the scale, and whether the scale is primarily being used for screening purposes or for tracking purposes. In the sort of late 2000s, around 2017, Health Quality Ontario produced a document that indicated, as part of a comprehensive assessment for major depression, clinicians should be utilizing validated symptom scales. And this is just a list of some of the ones that they recommended. So the patient health questionnaire, which is actually utilized in many family medicine clinics as well, only takes about 2 minutes. The quiz, which has been validated in both inpatient and outpatient contexts, has around 16 items, and it assesses for the severity of symptoms. The Beck Depression Inventory, again, also highly used in both research and clinical contexts. And the Zung Self-Rating Depression Scale, again, only taking about 5 minutes to complete. So the benefit of these scales is that they're patient rating scales, which means it can be administered to the patient prior to the consultation. It can be utilized on a weekly or more frequent basis to assess any change in the symptoms. It's important to consider actually having a discussion with your patient in terms of what would be the most appropriate scale. And lastly, these scales, because they're utilized in other specialties as well, can actually be a communication tool between psychiatry and other areas of medicine. So what is the evidence for measurement-based care? There are many numerous randomized controlled trials now on measurement-based care that show it improves outcomes compared to treatment as usual. And these studies have been conducted across various settings, whether that's inpatient, outpatient, across various groups. So for different types of disorders, whether it's major depression, bipolar disorder, schizophrenia, for various ages, youth, geriatric population, adult population, and also by provider types. So whether it's a psychotherapist that is administering the scale, or a psychiatrist, or primary care physician. I'm going to allude to a couple of seminal studies to talk about sort of the evidence. So the first randomized controlled trial that compared measurement-based care with treatment as usual was a study that was conducted in 2011 to 2012 at a hospital in China. This was a very large hospital with over close to 800 beds and servicing 19 million people. And as you can see there, the number of outpatient visits per day was tremendous. And their primary aim was really to look at the efficacy and safety of measurement-based care in patients with MDD. Their outcome was to track the time to remission and the time to response of treatment. And so their intervention included a very structured treatment protocol where patients were given the rating scale prior to the assessment, and dependent on the results of the assessment, they would then enter into a clinical decision pathway as to whether or not they'll be increasing their dosage of medication, whether they'll be switching to a different medication. And what the results show here is that, first of all, the number of patients who responded to treatment in the measurement-based care group was substantially higher, significantly higher than those who received just standard treatment as usual. This was both response and remission rates. The second finding was that the time to response was significantly decreased. So as you can see in this graph, for the measurement-based care group, those who responded took about 6 weeks to respond versus those in the treatment as usual group took about 12 weeks. And what really got me excited about this study was the time to remission. So MDD patients who were in the MBC stream took about 11 to 12 weeks to improve completely, to have no longer a diagnosis of MDD, versus those in the standard treatment group who took around 18 weeks. So if you think about that, practically speaking, what that translates to is a significant portion of time where the patient is no longer depressed. And this can have ramifications for their quality of life, for employment, for relationships. There have also been a number of systematic reviews and meta-analyses that have been conducted over the last several years, looking at what are some of the specific situations that really show an enhanced effect size when you have measurement-based care. The first study in 2009 conducted by NOP, which involved over 12 trials, and these studies were mainly for outpatient contexts in the USA and UK, showed that there was some small statistically significant short-term effects on using MBC for improving mental health outcomes. But when they looked at the sub-analyses for these studies, what they found was that the effect size is actually greater for outpatient settings, and also when patients are rating their own symptoms. Furthermore, in terms of the feedback that's provided, what they noticed was that the more frequent the feedback was provided and more frequently monitoring was conducted, this also enhanced the effect size. In 2015, another meta-analysis was conducted looking at studies that fell into 5 types of MBC interventions. So they looked at studies where the symptom scale was administered with no feedback, or there was feedback provided only to the healthcare provider, or feedback provided to the patient and provider, and also the type of feedback that was given, whether it was unstructured feedback or feedback also with suggestions around treatment. And this was based on evidence-based treatment guidelines. And so in this meta-analysis, what they showed was that the last category was the one that showed the largest effect size, when the provider is given not only the feedback immediately around their patient's symptoms, but also given information around how to guide treatment. In 2018, Lambert conducted another systematic review looking at 24 trials, and this resulted in a study that was basically surveying over 6,000 patients. And in this meta-analysis, what they showed was that the effect appeared to be stronger for patients whose symptoms did not initially improve than for those who did initially improve. So it seems to be that patients who are actually doing worse clinically would benefit from MBC. So I'm going to shift and talk a little bit about some of the benefits of measurement-based care for patients, for providers, and the healthcare system. This was an article that was published in the Globe and Mail 2 years ago, where they examined the pros and cons of measurement-based care. And so I recommend, if you have some time, to actually take a look and see what Erin Anderson had mentioned. Some of the highlights in terms of why MBC is beneficial is that essentially patients are able to improve in terms of their quality of life. As I showed earlier with the randomized control trial, the time to remission and time to response is much faster. And the other thing is that with MBC, what we're actually doing is encouraging more active involvement of clients. They understand their depressive symptoms better, they're introduced to the vocabulary around their diagnosis, and there's a way to then really pinpoint and track and identify what kinds of symptoms need to be targeted. In terms of the provider and the healthcare system itself, we also know that providers who utilize MBC are going to be able to identify if there are areas of deficiency in their own learning and in their professional development. There's also greater transparency and accountability, especially when the data is shared with the larger organization at large. It also leads to opportunities for quality improvement and also for performance review with training psychiatrists. Now, there are many barriers to implementation of measurement-based care. In fact, Lewis in 2019 wrote an entire article about the 17 areas where individuals can face implementation barriers. There's barriers at the patient level. So this can pertain to issues around the language of the rating scale that is selected, the time that it takes to complete the rating scale, whether there are issues around confidentiality, how the reported outcomes may actually affect the relationship with the physician or healthcare clinician. Also, for providers, there may be certain attitudes that are detrimental to implementation of measurement-based care. There may be a lack of knowledge around why do we have to use MBC? How is it evidence-based? There's also obviously administrative concerns or burdens, such as time issues, resource issues, the lack of financial incentives to implement MBC. And from a process and system perspective, if there are not sufficient resources for implementation, there's lack of training, there's no leadership support, again, this can really dampen the enthusiasm to utilizing measurement-based care. So based on the reviews, we can sort of conclude now what would make for an ineffective implementation of measurement-based care. And the first thing is there support for MBC? If the institution and the leadership do not support the use of data to drive clinical decision-making, it's going to be very difficult to have this utilized effectively. Are there local champions in measurement-based care? Are there implementation experts or quality experts that can help to facilitate the implementation plan? Some studies have also showed that for successful implementation, what we also require is a great deal of initial education around the benefits and evidence of MBC, and not only initially pre-implementation, but also providing ongoing supervision for clinicians. There are also issues around process and infrastructure. Relying on pen and paper and having someone to amalgamate that data by hand is very tiring and also time consuming. Also makes it very difficult to feed that information forward to clinicians. So studies that have showed positive outcomes have actually had integration of measurement-based care into their EMR. And so then clinicians can access that data very quickly, which then improves uptake. The last point here is that infrequent feedback or feedback that is given out of context actually is no better than treatment as usual. So just doing an initial PHQ-9 when you first meet a patient and then never really revisiting that data ever again or tracking that data longitudinally is actually no better than if you had done nothing. So when we go to the next presentations by Dr. Taube-Schiff and Dr. Stefan Kloiber, they'll talk a little bit more about how they were able to successfully integrate measurement-based care into both an inpatient context and also an outpatient clinic. In conclusion, MBC is an evidence-based treatment paradigm that utilizes systematic patient symptom rating scales to inform decision-making. I've already spoken about some of the benefits, but what we're going to be focusing on next is looking at some of the challenges and how these various clinicians were able to overcome those barriers so that it led to a successful implementation. I'm going to pass the time now to Dr. Taube-Schiff.
Okay, great. Hopefully that is working okay for everyone. So yeah, again, thanks, Karen. That was excellent. And it really, I think, set the stage so well for the talks and discussions that we're going to be having about that. And I love the fact of, like, you know, just taking that one initial measure and then not following up with it is so important because I think sometimes it can be really hard to integrate this in a meaningful way throughout a time that we have with the client, depending on the setting we're in, really in any setting. So such a good thing to think about. Okay, so what I want to focus on today is the idea of measurement-based care in intensive treatment services. And I'm going to use where I am at Sunnybrook Healthcare Sciences Center as kind of a model of what we tried to do. I'll talk in one moment, just a brief overview of the residential and day treatment service that we have and our goal to implement MBC within this setting. And we talked about why we want to do this and how we can do it. I'm going to talk about hits and misses and learning experiences along the way, and why we do it and how it's helped and where we're at now, which I feel is very different than where we were at to begin with. So some of you might know of us. I work at the Thompson Center for Intensive Services for OCD. It's a residential and day hospital program at Sunnybrook Healthcare Sciences. We are still running. We're a completely virtual intensive services program for the moment, and that actually allowed for some interesting opportunities in terms of our integration of MBC. We serve clients with severe symptoms of OCD that are treatment refractory to medication trials, as well as outpatient therapy trials. We serve up to 12 clients at any one time. We opened in 2017, and we've been a virtual program since May 2020. And with the hope, of course, of returning to in-person at some point. Our clients fill out measures at admission and discharge, as well as every week that they're in treatment. Currently, they're in treatment for about 6 to 8 weeks. And when we were in person, it sometimes extended a little bit beyond that time. Our measures focus on symptoms of OCD, symptoms of anxiety and depression. We also have measures regarding quality of life, as well as functionality, which in our population, given how severe their symptoms are to start, looking at how things change in terms of their quality of life and functionality is important. And these are patient, client administered measures. Other than one of our measures of OCD, it starts off as a clinician rating scale, and then clients will fill that out with clinicians reviewing it should there be any concern that the results we have on the measures don't really match what we're seeing in treatment. But for the most part, speaking to Karen's point, these are measures that clients are able to fill out for the most part on their own. So why would we do MBC in this setting? We felt when setting up the program that it's going to be very important to ensure that progress is happening. Clients that we serve have been unwell for many years, and we know from anecdotal evidence from other programs of this nature, as well as research that has since been published since our opening, that willingness and engagement is really paramount in this kind of an intensive setting. These measures provide us with an objective window into progress. We have a lot of subjective windows into progress from the treatment team that works with the clients, other supporting team members, as well, of course, as the clients themselves. We're a highly integrated, interdisciplinary team, and team settings and teamwork is certainly a theme of today. I feel very, very happy and privileged to work on a team where we all work so closely together, and really every client that we have ends up being known by pretty much all the team members as we work with them in different ways. So we really wanted to have something beyond just what people were kind of seeing, and to get that objective window as much as possible. We also felt that tracking these symptom measures over time can also help us to speak directly with the clients about ongoing progress and potential treatment barriers. Sometimes someone will say that, they're pushing themselves, they're doing really well, everything's going as they would hope, but we'll have measures that look exactly the same for, say, 4 weeks in a row. And measures aren't everything, but we want it to be, one part of the picture in terms of being able to have those conversations with our clients. So how do we collect this data? And I think that, Karen talked about some of these things as well. Initially, our data collection was kind of old school, one would say. It was paper and pencil based, photocopying everything. I remember doing that when we first opened, photocopying all the measures, handing them out, getting these large packages back, finding someone to be able to enter the data. Very labor intensive, perhaps not the most sustainable model. Team members really needing to ensure that these measures are being collected. We needed to create time in our schedule for them to be filled out. There was tons of paper filing. There was organizing challenges. I remember a time when we thought we lost a package, searching for it for weeks through kind of files and systems. And so it was how we did it to start. We did it for many years. Mostly we were paper and pencil when clients were in program until maybe 6 to 8 months before the pandemic hit. And then we started to change some of our systems, and the pandemic, as I'm going to talk about in a moment, really required us to change our data collection because, mailing packages and getting them back seemed, far too complicated. So there really was the idea of, taking a quality improvement lens to our data collection. And, prior to the pandemic, we had small kind of, QI rounds every morning where the team would meet and we would talk about different processes that were in our program, those kind of small huddles, those interprofessional huddles, kind of checking in on small QI projects that were going on. And the data collection was always a huge part of that in terms of, are we getting the data? Are we entering the data? Do we have the data for team discussions and team meetings? Do we have the data to be able to, have discussions with our clients? And how do we find people that can help us enter the data? And how do we actually integrate even giving out data during our program? And I oversee the programming for the program. And I remember we would look at the schedule together as a team and say, okay, we have to, cut something from the program. So we have like half an hour a day where clients are filling out these measures, maybe on a Monday for the week, and kind of trying different things. Do they stay after? Do we have a team member sitting in there while they fill out the measures to be able to get feedback and help them with any difficulties? And now we really have carved out time. We have a weekly measures time where it's a virtual program, but one of our staff sits in a link with our clients, and they're all, I'm going to mention REDCap and introduce that. That's the system we use for data collection. Some of you might be familiar with REDCap, but clients literally are sitting at their computers filling out their measures while a team member is there. Because at the beginning, we had a time that was carved out and there was no team member sitting in the link, and people would just shut off their screens and leave. So then it was a question of, okay, someone needs to actually literally be there and work in the link and making sure that packages are completed. We had to develop a system to oversee the packages not being completed and who was going to follow up with it. And I have to say, it really took a lot of coordination, because otherwise, if someone wasn't overseeing it, I know Dr. Wang talk about this idea of kind of needing a champion and an expert. It's really that idea of, who's going to follow up when this measure isn't filled out? Who's going to follow up when these packages aren't coming in? And kind of designating someone to kind of be that person that's going to follow up and make sure things don't fall through the cracks. And it took years, I have to say, to kind of figure out a system that worked. We have excellent data collection while our clients are in program. We kind of have our clients, captured, if you will, for 6 to 8 weeks, which is, very fortunate to be able to get all that data. We have a very difficult time getting data once they leave. And for those of you that know residential treatment programs, it's so important to continue to follow it. Maybe they're not within your care, but we have aftercare programs, so we still want to know how they're doing. We offer a lot of follow-up. So still getting that data and offering it to individuals to know how things are going, we still consider to be a very important part of the program. Okay, so we figured out how to get the data. And now what do we do with it? All this data at one point was just being collected, and our processes were a bit better, but we weren't doing as much with it. So now it was like, okay, we have the data. How do we present it to the team every week at our weekly meetings? So people have like structured, subjective reports, and we can like look at the measures together and see what's going on. How do we then present it to the clients? It's great if we all know it and talk about it, but how do they actually know what's going on? And as we heard about, it's so important for the clients to know as well. And how do we make it meaningful for them? Numbers aren't meaningful to everyone. These measures don't mean that much to some people that might not have, any kind of knowledge of these kinds of measures. And then can it be used to change the course of treatment, to inform our understanding of treatment, and to help the client look at it and say, okay, do I need to make any changes based on what's going on? Multiple trials and errors were done with this. We would include scores on a weekly treatment plan that was discussed by the team. Scores would be reviewed with clients at the beginning of treatment and at progress meetings, but it took a while for us to figure out how we really want to see it. Now we have graphs that we show for every single client when we're doing our team discussions, and we look at the graphs first to give us a snapshot of how our clients are doing in certain areas in terms of those symptoms and quality of life measures. So the team is like, okay, that's interesting. Like, I was going to talk about how much progress they've made in terms of their OCD symptoms, but there's been no movement. Could something have been filled out incorrectly on the measures? Does someone need to review that? Are we not asking about certain things that we should be asking about? So it's a really amazing kind of visual cue to the team every week to think about, this is what's happening. How do I incorporate that in my conceptualization and work that I'm doing? So I feel for the first time, we're really using it now to inform our care. If I had spoken to you a year ago, I would have a very different kind of take on that, because it really took us a long time to get to the point where we figured out, how does the team need to see it? How does the team need to see it? How do the clients need to see it? And visual representations, I think for the most part, tend to be a way that people can see things in an understandable manner. So as I mentioned, COVID changed our procedures, and I don't really know at this point what COVID hasn't changed in our lives. Not a whole lot. As I continue to kind of work from my home office after 7 months, but it really changed our procedures in that we pivoted to full data collection via a system called REDCap. Many of you might be familiar with this. It's an amazing system. I'm going to show you a few snapshots of it in a moment. It's basically like an online kind of system, like portal system, database storage center, where clients get sent a link, and then they open the link and they see all of their measures that they have to do for the week at admission and discharge, however you set up that system. And then they send you back, the link gets sent back to you, it gets resubmitted, and you have a whole bunch of data that can just get exported into data management systems that you might be using. So it eliminates the need for someone to enter data, which is a fantastic time saver. You still might need someone to help set it up, and I take absolutely no credit for that. I've been blessed to have some students that have been working with me and were able to set up the system in terms of setting up the questionnaires in the system, getting reminders on the system, etc. So that takes a little bit of effort for sure. Not as much, of course, as like, you know, entering in many, many measures. We now review our measures with our clients. We have progress review meetings, 1 to 2 progress review meetings throughout a 6 to 8 week stay, where I and the treatment team meet with every client and review progress and put it in the context of these measures. As I mentioned, the measures are shared with our team members weekly, and they're really used to inform treatment decision amongst the team and amongst the clients, which it's in a great state now. It went through many fits and starts, many different ways of collecting data, entering data, and discussing data. I couldn't show you, of course, a filled out measure just because there is some PHI in the system, but my database manager sent me a few snapshots. As I said, very full disclosure, I don't work that much on REDCap, but I do have some amazing people that have helped me with it. But from what they tell me, you can. Like, I've definitely gone into the system, and it's really quite user friendly. So you can see, you sort of get, you know, these are some of the different measures that you can see here. You can send, you know, email confirmations, and then you have, you know, the perception of care. Here are our admission measures. Here's our group evaluation, group questionnaire, weekly measures. So these things allow you to choose what you want and to send it out to your population. And there are some good video tutorials and things like that that people will use to get started on this system. And this is just a little snapshot of what it could look like if you're filling it out. So, you know, very similar to other kind of online surveys and programs that you might have used. It's laid out quite well. I haven't had any complaints from clients in terms of just the ease at which it gets to them or fill them out. Getting them to fill it out is sometimes the challenge, but not the system itself. I just wanted to really quickly, as I finish up, go through a little case example for kind of how MBC has been able to inform our treatment decisions. So we can imagine Miss Smith, who's a 35-year-old woman with long-standing symptoms of OCD. As you can tell by the little knife in the picture, this is a woman that has harm-related OCD. She has intrusive thoughts of stabbing people in her family with knives, pushing people down the stairs, intrusive thoughts of suffocating people with pillows and blankets. And that's just a little snapshot. In an individual like this, the list would probably be more comprehensive and happen in different areas and with perhaps known people and strangers. In response to these thoughts, Ms. Smith avoids using sharp objects. Only certain knives are allowed to remain in the house. They're locked up. Sheets and blankets must be well tucked under mattresses, so they would be very challenging to pull out. And she never walks behind anyone on the stairs for fear that she might push that individual down the stairs. So in terms of treatment progress, we can imagine that Ms. Smith began treatment and making progress, but some ambivalence definitely remained. Her reports to the team were that she was improving, but her measures seemed to suggest otherwise, and the team recognized that there were certain points that they felt we were quite stuck. So as you can see, week 1, she started off with a 38 out of a total 40 that you could get on this particular measure. We had a bit of a drop from 38 to 35 in week 2, a little bit down to 34, but you know, overall, we're looking at about a 4-point reduction over 4 weeks. So for those of you that may not be familiar with a residential treatment setting, very, very intensive. Literature shows us that the first 4 weeks are where we see the majority of our gains within this kind of a setting. 30 to 50% reduction in symptoms is very typical. So you often see a really nice drop at the beginning, and then it kind of starts to slowly dip over the last few weeks of treatment. So this is something that we would look at and think, uh-oh, you know, Mrs. Smith seems quite stuck. She's telling us she's sort of improving. We're seeing some things that she's doing. There could be, in our population, internal rituals, subtle rituals, things we're not that aware of. So then at this point, we might say, you know what, definitely time to have a progress review with Ms. Smith. We had one a couple weeks ago. Nothing seems to be moving. Let's meet with her and let's share these measures. Let's discuss the implications. Let's problem solve what's challenging together and try to have some objectivity into it. Does this always work? Well, of course it doesn't always work, but for some clients, for sure, I've met with them and they look at that and they think, well, I really thought that I was, you know, making significant changes. I wonder what I'm getting stuck on, you know, I wonder what we can do differently. And it just opens up some conversation that you can have, which is very different than a push-pull of, I'm making changes, and a team member's like, well, not really. At least this gives it that objectivity. It allows the client to see what's been happening, what hasn't been happening, and perhaps it can open up a really great discussion about elements that might not even be known to the team and really guide the treatment trajectory in that way. So in summary, you know, MBC really provides our team with these objective measures and this window into progress and challenges for clients in a way that is beyond the narrative that we want to be able to get as well from our clients and from our team members. It has been an iterative process to really understand the best methods for data collection, analysis, and presentation. And there's really an importance of the team using these measures, not just collecting them. So you really want to be able to use them in a way that is valid and meaningful. MBC can also really provide the treatment team and the clients with objective insight and provide opportunities for conversations to treatment barriers as well as modifications. I'm just going to stop sharing my screen for a moment. Okay, and I'm going to introduce Stefan, who's going to, I think, come up and give a talk. Sorry, I just have a few notes in here. Dr. Stefan Kloiber will speak with us now. Thank you.
Hello. Thank you so much. I'm very excited to share some of our experiences with measurement-based care around the major depressive disorder integrated care pathway, the MDD ICP, that we developed here and implemented at CAMH in our large clinic, the Mood and Anxiety Ambulatory Services. I hope you can see my screen. And just very briefly, integrated care pathways are briefly defined as a multidisciplinary outline of a structured care plan or algorithm which details essential and sequential steps in the care of an individual with a specific health condition. The benefits of such ICPs, it facilitates implementation of evidence-based care, creation of multidisciplinary teams, reduction in delay and unstructured variations in treatment. It allows implementation of measurement-based care and facilitates related decisions. It can improve the patient family care provider experience of care, and it focuses on patient-centered care and patient-centered treatment decisions. In our MDD ICP development, we had a process over about a year with regular meetings, consensus process, review and approval process. We included current guidelines, algorithm-based projects such as the previously mentioned STAR-D project, Berlin algorithm, Texas algorithm project, And we integrated pharmacotherapy, psychotherapy, and neurostimulation treatments into an algorithm that we felt was a good outline and a stepwise stepped care for these patients. In addition, the clinic prior to this implementation was physician-only model. It was a consult-based clinic with only few patients seen for treatment, and there was very few communication between colleagues, between physician colleagues, but also between physicians and other members of the team. There was a CBT group program running, but that was, physicians referred to that program, but it was quite independent, and there was only few communication within the team. And also a major factor in the integration, and I will share a few more experiences around that, was the IT infrastructure that we built for measurement-based care. And we also used the already demonstrated REDCap program, which was a great success for us as well. So the main elements of the ICP included the different treatments integrated into an algorithm of pharmacotherapy, CBT, neurostimulation, and clinical building of clinical teams and clinical team interventions, and the main aspect that the progress and changes in symptoms are regularly measured through patient self-reports. And what we think retrospectively, what we did and what facilitated the implementation was that we adapted to the already existing infrastructure and used integration with the current EMR, used the pre-existing CBT program, and institutional infrastructure. We had established a great collaboration with neuroinformatics at CAMH, the Brain Health Data Bank, who were very supportive and helpful in creating the IT infrastructure and help with setting up the clinical REDCap, initially for the in-person meetings where patients completed their questionnaires on tablets in the clinic waiting areas. Prior to COVID, and since COVID, with the transition to virtual care, including the measurement-based care aspect into like email links that are sent out to patients, and then patients complete these measurements. And there was already an ICP program at CAMH where under which several ICPs for different disorders were developed. And so the IT infrastructure was mainly used for measurement-based care, and we to avoid additional time and work and burden for physicians, we based the measurement-based care for the ICP on self-reports and self-report measures. And we created team meetings of about 5 to 7 physicians, nurses, social workers, administrative staff, to really regularly discuss complex patients and patients throughout their care they receive in the ICP. And we also provided the algorithm and decision support in an electronic fashion, in addition to the measures to the physicians for the next steps that are suggested by the algorithm in their care. We, of course, try to allow some flexibility, which we felt would facilitate the implementation. So we allowed, like we integrated different options at each stages of the algorithm. Shared decision making was one preference, including patient preferences and concerns, discussing the results with the patients, and the availability of all those treatments, including CBT, pharmacotherapy, and neurostimulation. In the next part of my presentation, I want to focus on 2 aspects that we think were very helpful in the implementation and the success of this treatment program. And it was the team-based approach, which was really culture changing in the clinic, and the IT infrastructure for measurement-based care that had several positive implications as well. With building the team model, we wanted to address several areas for improvement. So with creating teams, and our teams meet on a weekly basis for 1 hour per week. So it was kind of changing the culture of solo practitioners working in silos. So physician feedback was that they have like more contact with their colleagues, feel like better informed about what's going on in the clinic. We use these teams also for knowledge translation and knowledge generation and knowledge building of integrated care pathway aspects, but also measurement-based care. It was helpful to decrease the initial high caseload that was that some doctors were experiencing who piloted the MDD-ICP, and we were able to kind of facilitate the gradual introduction of a culture of measurement-based care with communication through these teams and regular meetings and discussions in these multidisciplinary teams. What the digital infrastructure, we thought this would really help with also providing tools for the clinicians, physicians, and therapists to really help them and decrease their workload rather than increase their workload when using measurement-based care. And so the IT solution that we developed should target the following aspects. So in implementing a culture of measurement-based care, embedding best practices, workflows, having a good data capture process, and technology in the care delivery, increase the capacity, collect data, evaluate outcomes, and an important aspect to provide the results of these measures and the decision-making support from the algorithm in real time to the physicians and care providers. So we are still working on this part on a complete visualization of the patient trajectory over time, which we hope to be implementing soon in collaboration with our colleagues in the neuroinformatics team, and also to use the infrastructure and the results for additional quality improvement and to inform research. We also started off with a paper-based model, a paper and pencil-based model, and it had several, we faced several difficulties with this and additional factors that were in the clinic happening, a lot of administrative tasks, documentation, doctors scoring the assessments by hand, entering those in the chart, and which of course was additional burden and administrative tasks for the physicians. So we created a system that where we used tablets in the waiting area. So patients were asked to come 15 minutes earlier for their appointment. After check-in, they were given the tablet for their self-report survey. They completed it. At the time of completion of the survey, this was the physician was informed electronically when the survey was completed, so they knew the patient was ready to be seen, and the results were available in a result page that could be easily transferred into the note, into the clinical note, and allow reduction of documentation time. We used as well clinical REDCap, and an important part was, as I said, the real-time presentation of results to the psychiatrists for allowing to include the most recent measures into the care decision. In the meantime, we have also been successful in partially integrating REDCap and iCare with the help of our neuroinformatics team. So we are now, some measures are directly going into the electronic health record, which makes it even more, even easier for documentation. And so we hope that we can further use this knowledge for quality improvement, program elevation, and that it also will feed back into clinical practice. These are some of the feedbacks we received from physicians and patients. So here the patient experiences, they felt they had a perceived value of these self-report assessments. They felt they were better informed about their care, and they felt the physicians are looking at the results and the survey results and discussing it with patients to determine the next step in their care and the next care decision. Feedback from physician included reduced time spent on administrative tasks and documentation, better able to monitor improvement in outcomes. It was felt that the model was more patient-centered, and it was really valued that the tools and results were delivered in real time. Some preliminary results from the Ontario Perception of Care mental health and addiction questionnaire. So we asked patients to complete this who participated in the MDD-ICP, but also patients who received care for other things in the clinic. So patients in the MDD-ICP compared to a group of patients receiving CBT programming or non-measurement based ICP care felt that they were better informed about their care. They felt the wait times were shorter for like starting the program, but also for like the appointments when they were in the clinic. They felt they had a better access to care. They were more involved in care decisions. There was more time to discuss with the physicians and the care providers about additional questions they had, because many of the questions were already answered through the self-report survey that are like usually repeatedly asked at each appointment. And at discharge, based on this tool, the Perception of Care questionnaire, they had a better understanding of their care and of the next steps in their care. And we also did a very short and small survey with physicians in the clinic and clinicians providing CBT, so members of the multidisciplinary team using clinical REDCap, and over 90% felt that clinical REDCap is useful, is a good idea to use in the clinic, and it's useful for the daily clinical work. Over 85% felt that learning to use clinical REDCap is easy and that they will use clinical REDCap within the next 3 months. And over 75% felt that it enables them to accomplish certain tasks in their daily work more quickly. And here are some feedback from feedback and some comments from physicians about the MDD-ICP model, and particularly the measurement-based care and the data capture and real-time presentation of the patient surveys. Patient surveys in our in our follow-up appointments include the PHQ-9, the GAD-7, questions about compliance, side effects, and substance use. So these are the 5 areas that are regularly assessed when patients are seen for their follow-up appointments. And with these comments, I would like to finish and thank everyone who contributed to this large treatment program. So far, over 900 patients have started and received treatment in the MDD ICP since we started in 2018. And thank you for your attention and for the possibility to present this experience and share this experience with you today.